Good afternoon. I'm Susan Gregor, Associate Director of Data Science at NIH. It's a real pleasure to welcome you back to day 2 of our workshop on policy and ethics of record linkages. We had a great meeting yesterday with some really thoughtful discussions on security, privacy, and today we'll hear from a number of panelists and speakers on participant perspectives of record linkage, as well as the ethics of record linkage. And then we'll close with a Connecting Main Ideas discussion panel. It's a real pleasure to introduce to you our first moderator for our first panel, Sharon Terry. She is the president and CEO of the Genetics Alliance, an enterprise engaging individuals, families, and communities to transform health. The Genetic Alliance works to provide programs, products, and tools for ordinary people to take charge of their health and to further biomedical research. She is also the co-founder of the PEX International Organization, a research advocacy organization for the genetic condition of connective tissue disorders that affect the elastic tissues of skin, blood vessels, and the eyes. She discovered the ABCC6 gene. She subsequently developed a diagnostic test and conducts clinical trials. She's authored over 150 peer-reviewed papers, and she's conducted at least 30 clinical trials on PEX. She's really an outstanding voice for the community, recognizing that all of us have a stake in biomedical research. And I'm just delighted that she's able to join us today and to really give us some ideas on the participant perspective of record linkage. And so with that, I'm more than happy to turn over to you, Sharon, and thank you again for joining us.
Thanks very much. So I'm Sharon Terry, and basically just a mom with a master's in theology. The sort of stuff that we're discussing here is not part of my career like it is for almost all of you. As Susan said, I'm the founding CEO of a research organization for PXE, a genetic condition my kids have, and I'm also the CEO of Genetic Alliance, which is an umbrella group for about 2,000 disease advocacy organizations and another 6,000 communities of all sorts, affinity groups, faith communities, underserved and marginalized communities. I'm not going to use slides because I want to look you in the eye, or at least the Zoom square while I speak, seeing your picture or your name. I'm not a researcher, and there are quite a few of you here who wrote the book. It is your articles that we participants cite to support our claims or are what matters. It has been said that if we participants are not at the table, we'll be on the menu. However, I want to say that we just need to decide how to construct the table, what to serve, who to invite. And so I want to tee up our breakout rooms with a few observations from my life as a participant and then broaden that to what I know about other participants. The most important thing is for me to say I cannot speak for all participants. There are some of you here who might say you're a participant too. Yes, part of you knows what it is to suffer from illness and to experience death. All of us ultimately will do that. That is the legitimate lived experience. My test in rooms like this is usually to say, who else can say, I don't want to be here. I never wanted to be here. I would love to leave this room. But life pushed me over a threshold I never wanted to cross, and I still wish I had not. And so here I am. So I can tell you about my experience as a participant, which is one perspective, and then I'll invite us to remember, imagine, consider all of the other participants, essentially all of us. My 2 kids were diagnosed in 1994 with a rare condition. I was shocked at the behaviors of many biomedical researchers, in addition to being shocked by the disease, which I'll not go into here. I have a TED Talk if you want to see that. Suffice it to say that I knew that after stumbling through 400 journal articles on pseudoxanthoma elasticum, PXE means never having to say that, these case studies couldn't be the answer, that data must be amassed. And so I founded an organization, I created a registry and a biobank, and I brought data sources together in 1994, 95, 96. I had people answer a 900 field questionnaire every year on paper and send me their records, medical records, all on paper. Dozens of other moms and dads contacted me to teach them what I was doing, and I joined Genetic Alliance in 2000 to scale the solutions I thought we needed and were being called for. I inserted us, moms and dads and children and aunts and uncles into the biomedical research complex as participants and learn to act like one of them. As Susan said today, I have 150 peer-reviewed publications. I manage a robust research consortium. I hold a patent. I have 6 treatments in various stages of clinical trials for PXE. I established and I still manage an IRB that understands people-centered is not a checkbox principle. Then called patient matching and now record linkage, this was critical throughout all of this. I created a system whereby individuals could control their own data and connect the data sets that they wanted to connect and decide who would access that. A few years ago, we took this to a new level with a partner, Luna PBC, a public benefit corp, that built a platform of which I could only dream in 1996. Participants own the company in which they share their PRO, their EHR, and their genomic data, genetic data. They have literal shares in the company. It's overseen by the SEC. The data doesn't leave the platform and it cannot be sold. And the platform and the company cannot be sold without every single shareholder consenting, agreeing. 26 years ago, when my kid's blood was taken 2 days after Christmas at age 5 and 7, a day later, another research team came knocking, and I told them they had to share with the first research team and not take blood from little kids twice. They laughed at me. "You can't herd cats," they said. I said, "Yeah, actually you can if you move the food." And so recognizing that the data, the biological samples, et cetera, was the food, and that participants have the right to keep a string on their data, the researchers now come, listen to the priorities of the participants in this platform that we're working on, and conduct research, bringing external data sets. Any community, disease or not, can use our system for registries and for studies across disease, across condition, across interest without silos. I give you this picture as one example of participants as at the locus, as at the center. I know you all have many arguments against this, such as too low literacy levels for most people to get organized or to be able to participate in such a system, or to make decisions about whom to trust. But in this trusted broker stewardship model, community-based model, the supports for individuals are different than the researcher, company, or clinician-centered models. Those of us with skin in the game, literally, are often told we have a conflict of interest when we are at these tables. The world in which we are meeting today is one in which the research incentives are not aligned with people's needs, but instead how to get data to researchers so they can get support to continue their work. I'm not denying that that's a noble enterprise. I'm just asking that we think about how we might really work on what matters to people and how to have a system that supports that. When we go into our breakouts and discussion, we have to remember that the people are not here. The rest of the people who don't want to be here, like I don't want to be here, are not here. We likely won't forget that we're talking about record linkage in a severely broken healthcare system. It's hard to imagine widespread implementation of systems like I described a moment ago. But still, I urge us to consider a shift in our thinking and recognize that there is no need to ask for trust, to cajole, to explain, to educate participants if what they care about and we care about is addressed, and if those needs drive the agendas. Today, we'll be working with the current state in which we must consider how fast and how far we can push the envelope. I implore us not to default to Father knows best or trust me, and I ask that we face this head on, not let convenience drive, but instead ask how the principles we decide on here give individuals, families, and communities the tools they need to advance discovery. I would like us to ask how we can be of service and how the solutions that we craft from this workshop can right the balance of power. How can we recognize the vastly different interests, sensibilities, fears, needs, and dreams of the participants in what we call principles and guidelines? How do we embrace the possibilities that cutting edge technologies offer? And at the same time, remember that we can make people and communities vulnerable in ways we didn't imagine. How can we recognize that each person is the expert of their own risk-benefit analysis and not gut them of their power? I realize I've not given you a landscape analysis or the elegant and erudite synthesis of which many of you here are capable. I bring you only one participant's truth, experience, and quest. Imagine this Zoom filled with the millions, nay billions, that need us to risk like they do every day. Risk the status quo, push for inclusion, equanimity, equality, and ultimately be guided by humility and an awareness that serves. Thank you. We are now invited to go, thank you, into breakout rooms, and I'll leave that to the organizers to describe for you. Okay, so we're going to go through the breakout reports from each group one by one, and the first one will be Rick Sharp.
Well, thanks. We had a lively discussion today, but we had a really lively discussion. I'm sorry, a lively discussion yesterday, but a really lively discussion today. And thanks to everyone for their contributions to that. Just briefly highlighting a couple of themes. One of the things we talked about in terms of participant engagement is that there seems to be a lot of emphasis on engaging participants around potential concerns or potential problems related to records linkage. And the group felt strongly that any systematic efforts around engagement should really focus on the benefits of the kind of biomedical research that would be enabled by records linkage. So yesterday we talked about decreasing burdens on individual research participants, but that broader benefit associated with the research itself, the research made possible by that kinds of records linkage, the group felt was really especially important. And given media attention focusing largely on scandals and problems in research, we thought that was a really important counterbalance in terms of engagement activities. A second theme that we talked about were a number of challenges related to participant engagement, and in particular challenges related to which kinds of patients you reach out to, using not-for-profit organizations as a vehicle for reaching certain patient communities, being viewed as potentially sort of biasing the kind of engagement that might take place. And we talked a little bit about some of the technical challenges involved with records linkage, in particular related to the language here, talking about de-identification, anonymization, et cetera. These are really technical ideas, and what that means in practice and so forth would be, I think, a concern for a lot of patients. And so trying to figure out how do we even open up space for that kind of conversation that would support robust engagement was one of the things that we talked a little bit about. Then we probably spent most of our time talking about what we might consider as patient-driven privacy sort of settings, that would be akin to the kinds of settings that we have on our social media pages and things like that, where individual patients determine for themselves what kind of information they want to share and with what kinds of users of that information. And kicked around some of the pros and cons to that kind of approach. But in terms of soliciting participant perspectives on health records research and what would be acceptable or not, that seemed to be emerging as kind of a gold standard, if you will, that we might measure other activities against. And then lastly, though we didn't have a chance to spend much time on this, I raised a question about the optics of enabling health records linkage to facilitate biomedical research when we don't have a national health records data set that supports patient care activities and supports continuity of care across different medical institutions. How members of the public might view us pushing, us being the federal government, pushing for a records linkage system that supports research when we don't do this in other settings could be an important consideration for some members of the public. So again, we had a pretty wide-reaching conversation, but those are just a few highlights.
Great, thanks, Rich. Okay, let's go to the next one, Tony.
I would describe our conversation today as thoughtful and complex. It wasn't fiery like yesterday, but it was very, very thoughtful. And beginning, in a sense, with the principles that we ended up with, that benefits and risks should be communicated with equal clarity to patient and stakeholder communities. Now, we've spent quite a lot of time discussing the risk of re-identification and what the dangers are. But some significant benefits have arisen from data work, and it is worth communicating these to our communities so that we don't lose the benefits simply because we failed to communicate them. Then we've spent, again, a little bit of time thinking about special populations. Special populations are kind of both uniquely able to benefit, but also uniquely vulnerable. And it was pointed out that this isn't just the cases of rare diseases, but also religious groups, immigrants, and in particular, people who can be identified in a particular way, and whose data then does make them more vulnerable. And we discussed the concept of opt-in and opt-out models. This, for example, is represented in Sharon's example, and as Devon described what her organization Citizen is doing. And we touched on questions of consent and reconsent. And looking at the list of, I wonder if I'm forgetting some things, colleagues in the group.
So, Tony, I would like to include in the list something we discussed regarding non-human status for certain data to be linked, and how this applies to privacy and ethics of linkage, because that definition transcends the linkage per se, but it's used by IRBs all over the place. So once the data is truly de-identified and considered by IRBs, for instance, non-human, should that be within the scope of what we are discussing in protections to individuals or not? And that's a question. It's not an affirmative in any way or form, but it's an important one to this discussion, in my opinion.
Yeah, and something that occasionally rears its head is the statement that de-identification is a myth.
Yes, great. Thanks very much, Tony, and your group. Next one is mine. Yes, and I'll say we definitely know de-identification is a myth, and whether or not we should be calling anything human not human is another discussion. So in our group, again, to try to do justice to this, difficult as usual, we started with linkage happens. There could be a bumper sticker, but people don't know it, and that it's different in whether it's a small clinical trial, large clinical trial, or just the kinds of data linkage that are happening for the healthy, for health services and so on. Do the data resources have the representation they need, or are they disembodied resources? And that goes to the point I think we just talked about, as well as other ones like, are, for example, community leaders and advocacy organization leaders the best representatives of the people? And often, I'll say this from being an advocate, we often have a different agenda than the very members. And so the disconnect there is difficult. We talked about implementation science, engagement science. I'll throw in also computational social choice and some of the other sciences that have been used in other parts of the world, and that any of these are going to need real measures and accountability, some of which have begun to be formulated, especially in other disciplines, and we seem not to take up that learning so easily. And then in NIH learning and recommendations, more discussion, harmonization, considerations across the ICs. Some are doing things well and some are not, and they could learn from one another. One point might even be that more common language around consenting and benefits and risks and all those sorts of things could start to become more ubiquitous across NIH, PCORNet, and others, including those not funded by those entities. Guidances on privacy linkage more clearly. And we also discussed how to communicate the benefit and who communicates that. Do we just trust you, trust us, daddy knows best sort of thing? Or is there some way for that to come, again, more from the communities themselves? So that's our group. Again, not a great summary, I'm sure, but to keep us on time, I'm going to move to Pilar.
Thank you. And I just wanted to say for Umberto, there is a terminology that has been coined for that research that is not regulated human subjects research, but that still, for instance, involves data pertaining to humans. So Ellen Wright Clayton and colleagues have called that human non-subjects, right? So it's not regulated, but it's still about humans. All right, so our group, we did start out with addressing this first box and talking about the fact that we felt that overall, and this relates to Sharon's group, that there is a relatively low level of awareness of data collection and use and linking in people's lives. And that includes in healthcare systems and medical research, but it's an issue that goes far beyond healthcare systems and medical research. And like others, we thought that there's a wide range of kinds of data sets that could be linked, and we could be talking about things that are more closely related, like if somebody's in a clinical trial, linking to their electronic health record. That's something pretty constrained and maybe easier to discuss with participants in a clinical trial than some other kinds of linking that might be done. And so we felt like, part of the issue here is to define what kinds of record linkage you're talking about. And it's hard to think about what the communication strategy should be if you talk about this in the abstract. We also had a really interesting conversation. One of our participants had done some research with his own research participants and found that, and asking them about what records they might be comfortable having shared, examined, linked, and found that there was really a distinction that some people took a very rights-based approach, and they didn't contemplate so much whether a certain use of their data was more or less risky. Instead, it was about, this is data about me, I have certain rights in it. And so that there was a distinction between rights-based approaches versus more consequentialist and risk-based approaches among his research participants. And I think that's probably, well, we have data to suggest that distinction is fairly widespread among people, right? And so, one of the questions was like, how stable is this kind of distinction that people make? How is it influenced by the way you frame your questions, and so forth and so on? We also talked about the fact that there are piecemeal approaches to allowing people to articulate their preferences in these regards about how much should be shared and what could be linked. But we don't really have good norms for doing it yet. We don't have a community agreement among researchers or a broader community. We also talked about how different kinds of communities might have very different perspectives for historical reasons and for reasons having to do with power in the broader society. And I think I'll stop there because I'm probably already over time. And if anybody in my group wants to add anything, please chime in.
Okay, and there's been some very lively chat, which we can read. And I like that we get to have both of these happening. All right, so Pilar, I think I pass it back to you.
I get to introduce Rich Sharp for our next session. So Dr. Richard Sharp is the director of the Biomedical Ethics Program and Center for Individualized Medicine Bioethics Program and the Clinical and Translational Research Ethics Program, all for the Mayo Clinics. And he's been a mainstay in the genome ethics community for quite a while. And so Rich is going to introduce our topic of ethical issues, and take it away, Rich.
Well, thanks, Pilar. I really appreciate the opportunity. It's always nice to be introduced with a close friend as well. So I very much appreciate that. And you never know what you're going to get from an introduction from a close friend. So thank you. So today I'm going to be very brief because I feel like we have anticipated a number of the comments that I might have otherwise made in this context. And so I just have a couple of slides here. My slides are displayed for everyone, is that correct? Okay. So I wanted to go back and kind of remind us about some of the ethical issues that Pilar had highlighted in her introductory comments. And this was a slide that you'll recall she didn't really unpack for us in a great amount of detail. So this is fortunate to be able to revisit some of that content. She highlighted for us a number of issues that you might broadly think of as traditional sorts of concerns in the biomedical ethics community. So first and foremost in this setting would be concerns related to the protection of the privacy interests of patients about whom the health records pertain. To what extent are we confident that those data would be maintained in a secure manner and that the privacy that patients have is preserved in that setting? Presumably, we'd want to have enough confidence that those same protections are parallel to the protections that they enjoy in the context of clinical care that they may be receiving. Second, she mentioned a number of concerns related to authorization of use and framed this in terms of informed consent. And I think in the previous discussions that we've had in the small groups, we've really raised the question of whether informed consent is the right model to employ in a situation like this, or whether something that might be perhaps a bit more dynamic in terms of its interface with patients would be a more appropriate model. Perhaps soliciting input from patients over time about the kinds of health records linkages that they're supportive of and those that they may be sort of unsupportive of. And then she highlighted some questions related to governance and how to ensure that there's appropriate accountability and oversight for new systems that would be enabled by health records linkage and processes associated with patient engagement. And I think that this is an excellent list. I think if you were to ask me to do this, I would have come up with a very similar list in advance of our meeting as well. If we could go to the next slide, please. And I think that list of sort of ethical considerations here might be distilled down even further to say that at the end of the day, what we're hoping to do in this setting, as in so many other settings involving clinical research, is to find that right balance between enabling systems that we ultimately believe are going to advance our medical knowledge and are going to promote new cures and treatments for patients, but doing that in a manner that doesn't expose patients to inappropriate levels of risk. But I think there are some things that we can learn from history here in terms of how we've found that balance. And we have to be reminded about the fact that we are at a particular historical moment in time that may color the ways in which we think about that weighing of potential benefits and risk. And for me, what immediately came to mind as I was thinking about this kind of activity were parallel experiences that ensued in the wake of the Henrietta Lacks scandal. And in particular, the concerns that were voiced in that context, I think, revolved around the fact that there was a commercial application of tissues, in this context, residual tissue from Ms. Lacks that was used without her authorization, without her family's awareness, and ultimately gave rise to enormous amounts of profits for those organizations that were sort of involved in developing and ultimately marketing HeLa lines. And we can quibble a little bit about how much of that was commercial and how much of that was in a not-for-profit space. But at the end of the day, there was an awful lot of money exchanged, and that money was derivative of tissue that was taken from Ms. Lacks for that purpose. Another historical lesson I'm sure that we'd all take away from that context was that that episode is associated with disrespectful treatment of Ms. Lacks as an individual, lacked transparency, lacked clarification with regard to whether she or her family had any ownership claim over those tissues that were extracted. And the rationale for doing that was not certainly known to her or her family in that context. So as you think about these kinds of historical precedents, I think we should be cognizant of the fact that we do not want to find ourselves on the wrong end of history with regard to thinking about the pooling of health records to enable biomedical research. And these same sorts of historical concerns about whether there may be a hidden profit motivation in play, whether doing this is in fact something that patients are supportive of and aware of, and so forth, are the same sorts of concerns that we should have on the table as well. And so I'd like to make what I hope is a relatively modest proposal here and solicit input on with regard to what I think it would be, what I think we might be doing if we're attempting to be deserving of the trust that patients have typically given us in terms of the stewardship over their health records. And it seems to me that distilling this down into a set of principles that might sort of anchor that process, I think first and foremost, we need to consider the issues that Pilar raised for us earlier. We need to be cognizant of minimizing potential risk to participants, and we need to be sure that there is some patient authorization for the aggregation of those health records into biomedical research tools for future use. Additionally, in our moment in time, I'm thankful that there's a lot more awareness of the importance of matters related to health equity. And I think that our patients and the communities that we support would certainly be concerned that the benefits that might flow from this kind of health research are distributed in a manner which is fair. They will ask us why they or their communities or their families are likely to benefit from these sorts of applications, and we should have answers to those important questions. I think that it's also important that we consider the alignment of this kind of federally sponsored activity with the goals of individual patients and the communities that they come from, that we should afford patients an opportunity to modify their participation in health records aggregation activities over time. At one moment in time, they may feel very strongly that this is important. At another moment in time, as their health records change as a result of illness and illness experiences, they may feel that there's additional sensitivities in their health record that make it the case that they no longer want to continue to share those records. And I think it's important to allow people to modify their privacy-related settings over time, to use that metaphor. And lastly, something that's been an obvious theme, I think, in the conversations we've had over the last 2 days is that there needs to be ample transparency about how health records are used by researchers, by which researchers, and what sorts of applications of those pooled resources would be out of bounds. Because without that kind of information, patients aren't going to be in a position to know whether they're supportive or not supportive of these activities, because we won't have told them enough to allow them to make an educated opinion. So I'd leave you with one sort of final thought in terms of thinking about stewardship. I think those are the things that we should be aspiring to when any sort of governance or policy related position related to the combination of health records to enable biomedical research. And I would say here that one of the things that I think is quite evident to those of us who've thought about DNA biobanking and other analogous contexts is that a one-time open-ended permission to use sort of health records for research is a very, very limited mechanism for trying to accomplish the goals of ethical stewardship that I've just outlined there. I think for me, that points to a limitation with traditional models of informed consent that are widely used, but simply don't work in this setting because, again, of the dynamic nature of an individual patient's health record, but the quickly shifting landscape of big data research and the kinds of data sets that are increasingly being combined with medical records data to facilitate additional types of studies. And by that, I mean browser histories, information from wearables, consumer purchasing behaviors, and so forth. All of those data sets are potentially combinable with health records in ways that would create very new and unusual types of privacy risks for patients. And so asking patients to essentially sign on and authorize the use of their health records for all future clinical research studies, in my opinion, is just out of step with the reality that we live in today. Okay, and that's all that I had to say. Again, I promised to be brief. I hope that I was, and I hope this was something provocative to sort of anchor the small group discussions.
Well, I think we are going to go back into breakout sessions, I believe. Is that correct?
Again, just want to say thanks to the whole group for participating, and thanks as well to our NIH colleagues for weighing in quietly and allowing the conversation to flow as well. I thought that worked very well. In summarizing, I'll just have 4 small points here, but in summarizing this, I do feel like in some ways I'm reconstructing a conversation here. So I do apologize this time around. This feels like the summary may not do justice to the richness of the discussion that we had. But the first point that I wanted to share with a larger group is maybe a sort of an overarching theme for the conference. And that's that in many ways, what we talked about was that the moral complexities of records linkage research are really just very much inconsistent with the existing policies and regulations that we have for the conduct of human subjects research more generally. So for example, one of the things we talked about is that it's illegal to sell PHI, but we can sell de-identified data. And all kinds of hospitals and healthcare systems have entered into commercial relationships that involve access to PHI as well. So it seems like the current status is that there are a number of regulatory inconsistencies and policies that fail to really connect with some of the more nuanced ethical issues that are in this space. And I think as a group, there was strong consensus around the idea that mere compliance with the laws and regulations that are relevant here would be insufficient to guarantee the ethical conduct of health records linkage research. And so I think that's a really important kind of high level confirmation of the need for this kind of meeting. The second point that we sort of settled around here was that in some ways, if we're going to think about specific policies or governance structures that would be appropriate, we're limited by the fact that there currently isn't a strong moral consensus around the guiding ethical principles that would govern that activity. And so here, the analogy that came to mind for us was the analogy with the so-called common rule, which is the set of regulations that govern human subjects research. Before the common rule was created, there was an important predecessing activity, the National Commission's work, which ultimately resulted in the publication of the Belmont Report. And those guiding principles enumerated in the Belmont Report became the groundwork, if you will, or the blueprint for the federal regulations. Here, with regard to health records linkage, I think we're limited by the fact that we don't have a comparable blueprint, if you will. And so without those guideposts, I think it's tricky to think about the specific governance structures that would be appropriate in this setting. One thing we did agree on, though, is that when it comes to health records data often contains deeply personal information. And the theme that ran through our discussions over yesterday and today was the idea that data comes from people, and we can't lose sight of the fact that that's the case. And then similarly, what that may mean is that with regard to data scientists who are using those kinds of data sets, there may need to be a requirement for some sort of additional training or documentation of familiarity with some of these matters, because the kinds of professionals that might be interested in conducting this research are really quite different. And the ethical commitments that a physician scientist may feel to her patients is probably a little different than the feelings that a data scientist who doesn't have those connections may feel to the data after it's been depersonalized in a certain way. So we thought that an additional training curriculum supporting this activity may be something that NIH would want to consider as well. And then lastly, we talked about the fact that any governance structure or policy in this space needs to really account for the fact that public opinions about these matters are not yet stable. And it may be the case that opinions about certain kinds of data science change in coming years as new types of data pooling activities take place, potentially combining health records data with other types of data in ways that create public concerns. So we felt it was very important that whatever structures of governance that emerge, that they provide ways in which we can go back to the individuals about whom that data applies to reassess whether or not they're still supportive of the kinds of health record linkages that have been created over time. Okay, so again, apologies to the group if I missed anything. Anyone like to add to that? Okay, thank you.
Okay, again, a lively and thoughtful discussion this session. And summarizing it is not going to be easy, but one of the things that we did begin with was the thought that, or the knowledge that data linkage, in fact, is ubiquitous in our society as things are at the moment. In many ways, it would be very easy to explain to someone what data linkage is if they've ever experienced an unexpected advertisement in a Google search. But making this the kind of leap that some people do suggest that, you know, there's no privacy, get used to it, it is not an acceptable step for us. And that we need to think very carefully about the data that we might link, inherit all the permissions and all the restrictions that they were subject to at the, you know, before any linkage. The second point was something that we mentioned in our previous session as well. In fact, the special populations are both the ones most likely to benefit directly or most directly, and also possibly the most vulnerable. And there's an ethical imperative to explain and describe the benefits before we go ahead and do data linkage. You know, why do we want to do it? If, as Devon said, if there isn't a clear explanation of benefits, you probably shouldn't be doing it. Then, in terms of structures for approval, we made a particular point of situations where certain data sources may be trustworthy, known to be trustworthy, and therefore could be subject to some form of blanket approval without going back to the IRB each time. Again, that ethical permissions should be designed to promote the common good and not be solely concerned with profit or harm. And that current policy should be leveraged to their most advantage, balancing the value side and the penalty side, balancing restrictions and permissions. And finally, in terms of what distinguishes our work from, say, you know, the kinds of permissions that we give with social media and the like, is that, again, a very strict distinction needs to be drawn that notice of a privacy practice is not informed consent. Secondly, that the quality of the data that you're going to link with needs to be very seriously considered in approving a data linkage. That it's not, you know, that certain data by themselves may create risk or harm. But on the whole, we need to communicate the benefits much more clearly than we do. I think that's it.
For my group, we began and threaded through and ended with a concept that actually the anchoring of all of this, even the questions here perhaps in traditional systems that are old structures, is not going to serve us well. The barn door is open, and that the ecosystem already exists around big data, around a lot of interchange of data and linkage that isn't that's in the wild and not really governed even by some of these along the way, we talked about whether we're talking about individual consent or group consent or individual governance or group governance, how IRBs and DACs differ, and even their consideration of those things. And in some sense, there's a two-state solution there that allows some things and not others. And so there's disparity in how that's treated. We talked about how we link to governance that's already in existence, especially for communities like tribal communities, and respect their ethical principles, and then use outside, essentially, governance that may not flange well with that, and that the risk doesn't go away in secondary use, that we need to consider care ethics at the same time, since in this life cycle of data, where we're pretty proud of learning health systems, et cetera, we are now integrating 2, 3, 4 different kinds of systems that used to be somewhat siloed. We talked about the pre-competitive nature of some data and then its use for generating IP and what the governance around that should be, as well as the fact that in some instances, even NIH itself is using commercial partners. And while those technologies might be interesting and useful, then the ramifications of data owned by commercial partners at the end of projects isn't always thought through all the way. We talked about who should be at these tables making these decisions. And certainly, while I argued that we need participants, people at the tables, there also is an argument that the data scientists and those who are disconnected from the humanity or humanness of the data also need to be learning about the fact that just because you can build something, maybe you shouldn't be, or that you should be thinking about what you're going to do with it. Issues around genomic data, and that linkages are already there in ways that we don't always pay attention to, and that we start to see we might need and have a very complex matrix of governance across what kind of resource is it, whether it's EHR, genomic data, PRO, data sets coming in from other kinds of secondary use and commercial and financial entities that are intentional and unintentional, and that we haven't planned for the inherent linkages that occur in those. And then also talked about in cohort-based studies, linkage as a benefit in the sense of reducing burden and especially time, but also understanding what the ramifications of that as we went through as well. That's it for my group. Badly reported, I know, but here we go. Pilar.
Thanks. It's interesting. I feel like several of the groups talked about similar things. So we certainly talked about aspects of data that are in the commercial domain and how they're kind of not governed, and that some of the PII and PHI that in academic side, we have to work hard to get access to that and use it and link it. People, basically, quote unquote, de-identify it, sell it. And that same data is out there in a commercial entity being linked to all kinds of things without anybody's knowledge or consent, probably. And without really any oversight or governance of that. And so, one of the concerns in our group is that this means that the knowledge is being privatized sort of by default, because it's a lot harder to do this work with public funding and research oversight than it is to do it in the private sector. And so a lot of the knowledge is being generated in the private sector and kept, behind a confidentiality firewall, basically, behind a business confidentiality firewall. And so that was a concern of ours, certainly. Which is not to say that we should all just go acting the way businesses act, but rather one of the things we considered is how do we then create more incentives for people to participate in the public research side of things. And I don't know that we came up with any really strong ideas. We thought about benefits, but we also thought about, actually articulating benefits more carefully and clearly. And so, for instance, talking about the time frame in which benefit might be expected, and for whom benefit is most likely to arise or to arise first, and that communities are not all going to benefit equally in many cases, and particularly with health research, where if the goal is to improve some aspect of a healthcare system or to deliver some new healthcare intervention, people who are already receiving very low quality healthcare are just not as likely to get that benefit. So it's not clear how we translated the concern about creating incentives into thinking about benefits, because we did talk about not overselling benefits, right? And not trying to sort of hype benefits inappropriately. We also talked a lot about the fact that this work is, a lot of it is actually not overseen by IRBs, that a lot of it is determined to be human non-subjects work, but that IRBs and institutions differ in making the judgment about whether it is de-identified enough, if you will, to fall outside the scope of the regulation, and that this is troubling for institutions, and that it's not a problem that is fully addressed by using single IRBs, because the determination about whether something counts as research on human subjects or not is still made at the local institutional level. And so it seemed like there might be some way of providing more guidance for IRBs, understanding that, going off of something that was in the chat, that de-identification doesn't mean zero risk of re-identification. It means it's a probabilistic question, right? That de-identified means lower risk in terms of privacy and re-identification, and there's a spectrum there. And so there are judgment calls and values that go into determining when the risk is low enough that something falls outside of human subjects research regulation, but that there might be some way of standardizing those judgments and providing guidance or examples and things like that. We also talked about the fact that IRBs maybe aren't asking the right questions with respect to data science projects. So like some examples were that they're not asking about how you make decisions about with whom you share, right? And that in some cases they are asking questions that are the wrong questions because they don't necessarily have the expertise to really evaluate this kind of science, and they are not necessarily up to snuff. And frankly, I will just add this editorial point, maybe the regulatory frameworks that they've been working with are not extremely well adapted to evaluating this kind of research. The point was also made that sometimes perhaps the determination that it's human non-subjects and not regulated is a way for IRBs to not just to kind of throw up their hands and not take responsibility in a domain where they feel very overstretched and outmatched, if you will. And I'll just end with this last point, which is that privacy isn't the only ethical concern. So this point was strongly made that there are other potential risks, there are other benefits, other things to consider. And so even though privacy gets a lot of focus, it's not the only ethical concern. I'll stop there. Now we're moving on to the panel. And so our panel is going to be moderated by Professor Sparrow Manson. So Dr. Manson is Professor of Public Health and Psychiatry. He's the Director of Centers for American Indian and Alaska Native Health and Associate Dean for Research at the Colorado School of Public Health at the University of Colorado. And welcome, Sparrow.
Thank you, Pilar. Connecting main ideas, an enormous challenge given the richness of our conversations, which have been very engaged and robust. I think the panel summaries of each of the breakout sessions have really underscored the wisdom of this particular approach, because although there are common themes that cut across them, the participants reflected a wide range of varied views and positions and perspectives on the subject of the last 2 days. I'll not introduce our panelists today in the same formal fashion. They're all well known to us. Of course, Pilar, Richard, Sharon, and Tony, who've done a wonderful job in their individual presentations, as well as orchestrating the individual breakout groups and reporting back to us in our entirety. We did think about what are the next steps in putting three major questions to the panelists in closing today. The first question has to do with how do we move from initial outreach and engagement of key stakeholders, as we witnessed the last 2 days, to solicit their views on the topics discussed yesterday and today, to sustain an inclusive process that goes beyond the important but yet episodic conversations at meetings and workshops such as this. This is, I think, as noted in some of the breakout sessions, not the first, nor will it be the last, but how do we engage, sustain, and bring some sense of coherence to these conversations beyond today's effort? The second question is, our discussion of research participant consent, whether it be individual, organization, or at the level of community collectively, underscores the complexity of this process. So how can we remain open to discovering the meaning and locus of consent across constituents and incorporate the subsequent insights into human subject protections? And the third and last question before us this afternoon is, over the last 2 days, we've explored many issues associated with NIH pilot studies of record linkage, related privacy and security, research participant perspectives, and ethics. Now, how do we bring these distinct conversations together? Is there an appropriate, desirable form of governance to coordinate such efforts, thereby ensuring that these matters are addressed and remain of attention to all of us? So let's spend approximately a third of the time remaining to us, and I'll orchestrate some of that. So any of the four panelists, if you care to begin, let's begin with question number one. How do we move beyond this initial outreach and engagement of key stakeholders?
So this is something I'm willing to launch into. This is something that I've seen done very well on a relatively small, intimate scale. And I'm thinking in particular of, for example, our PECORI CRN Capricorn, where we have a patient and community engagement group. And it's very easy and accessible to both sides to speak to each other directly. At the other end of the scale, as someone who has volunteered as a subject in All of Us, I get the occasional email and request to fill in a survey, but I feel really very remote from the project itself. So I've really come to the conclusion that intimate, small scale work is the only way that would succeed in this respect.
Yeah, yeah, I would agree with that. Yeah, so I would agree with that and say that we could be more systematic and supportive of that kind of engagement. In my small group, I made the extremely unscientific remark that when I was one of the legs of PCORnet and we looked at how much money was being spent at engagement by the engagement committee, including some people at Capricorn, it was very little money. Even in the institutions where we say that we are supporting engagement, we give very little to it and expect that it will float on its own. So I think I love, and this may be moving into the second question, which we're not going to do yet, but I love following the money in the sense of saying who has the hammer here, who has the carrot, who has the stick, and it's the funders. And in this case, probably NIH as the biggest funder in the US anyway, could be making better forays into this with community. So doing it not from the top down and mandating it from some academic center that they have to go find a community and do X, Y, Z, but instead going out to the communities, allowing, for example, their own branding on things like All of Us, which is not allowed, or allowing that those communities would actually make statements about the priorities of those communities, and doing that not just in, for example, advocacy communities, certainly love to see us included, but also in Native American, African American, all kinds of people of color, Pacific Islander communities, Asian communities, and the other marginalized communities that are either living in rural areas or living in food deserts in urban areas, et cetera, where there are good organizations that are working on social issues that would be happy to speak to these questions.
Yeah, I would just echo that. I also agree that any robust and meaningful engagement activity really has to be local. People need to feel comfortable in familiar settings, especially when we're asking them to potentially speak truth to power with regard to expressing unpopular opinions. So I think leveraging existing patient and family advisory councils that a lot of healthcare institutions have would be one strategy for doing that. Tapping into community advisory boards that may exist in clinical and translational research settings and so forth would be another strategy for that. But the downside of that is how do you actually make that possible? So here is a suggestion that all of my research friends will no doubt remember and will be very unpopular. Why don't we make it a prerequisite of participation in any data record linkage activity that the participating institution or an investigator from a participating institution has to document some form of community engagement activity in order to tap into that resource. There is some precedent for this, right? In the sense that we have a regulation. It's not a very widely used regulation that pertains to emergency research, where if emergency research is to be done in a setting where you can't obtain consent for participants, the person conducting that research has to carry out a community engagement and notification activity before an IRB can approve that. I would think that something that might be analogous to that here, that requires local engagement take place and maybe has some requirement that that engagement activity route up to some federal entity for additional input and be accommodated and sort of incorporated into planning, might be a model that would work. But again, I recognize that would be wildly unpopular with many of the folks that might be interested in supporting that kind of research.
Well, thank you, Richard. And in fact, at NIH and a number of ICs and initiatives, there are those expectations. The challenges becomes what's an authentic and credible commitment in that regard, apart from just simply checking the box and getting a letter of support. How does one demonstrate that level of expected participation in a truly multilateral fashion? So thank you. Pilar, an opportunity for you for a last word on this before we shift to the second question.
I don't have a lot to add. I thought those were all wonderful comments. I guess the only thing I would say sort of follows on this very last point, which is that there are two challenges. One is doing the engagement in an effective, fair way. The second one is, what do you do when you get that feedback, right? What are the mechanisms for incorporating that, for allowing for like changes of research protocols, changes of policy, right? Because people will be ultimately dissuaded from participating in community engagements if they feel like they come, they participate, they really give you their feedback, and then they don't see any impact of that.
Yes. And in fact, somebody earlier may have been Sharon said, follow the money. And of course, we know that community engagement and the kinds of processes and protocols we're talking about are typically underfunded by sponsors and not seen as part of the scientific enterprise, which I think is a misperception of the possibilities of that. Well, thank you. Let's move to the second question. And I suspect we lost Tony. Hopefully we'll be able to have him join us again. The second question is, our discussion of research participant consent, individual, organization, collectively, underscores the complexity of this process. How can we remain open to discovering the meaning and locus of consent across constituents, whether that be individuals, organizations, or communities, and incorporate those insights into human subject protections?
Why don't I maybe take the first pass of that one, if it's okay? It's sort of the research ethics one there. I guess one suggestion, I heard hints of this throughout the meeting, is to consider the possibility that informed consent really isn't the right paradigm here. You know, when we ask for consent, we're usually asking for permission to do something very specific. I don't know if that's baked into the etiology of the term, but it certainly feels that in application, that's what we are asking for. Can I do this to you at this particular moment in time is the question. And with regard to this kind of research enabled by records linkage, we're really asking a different kind of question. We're asking, would you be supportive of this general concept? And we're happy to come back to you in time, presumably, and tell you more about that, should in fact you be interested. And I don't know what terminology refers to that concept, but it's something that has a longevity to it that's very different from the ways in which we think about consent in most cases. And it also has a quality that I think we're talking about in our small group, of potential for change. There's some reason to think that there could be adjustments in preferences that would impact willingness to provide consent. So I think we have to embrace this as a more dynamic kind of authorization that could be modifiable over time, that could actually be modifiable based upon a change in a substantive preference that that individual has, but it also could be modified in light of a changing research landscape in which data uses expand beyond the scope of what we originally envisioned to be possible. And in that regard, I'm glad that there are so many people that are here from the genomics community as well, because the kinds of informed consent that we used to get for DNA biobanks 15 or 20 years ago would never in a million years go through an IRB today. And it's not because people's attitudes about genetics have changed dramatically. They have changed to some degree. There's more acceptance of genetic research, for example, but it's the technologies and our capacity to do increasingly more detailed analyses of the genome that have changed. And I think we should anticipate that data science is still in its infancy with regard to health records research. And we're going to see all kinds of advances that none of us are well positioned to anticipate today. So I'm not sure consent is the right concept for us to be using in this setting.
Thank you, Richard. Sharon, you were going to elaborate.
I was first going to say we have to stop asking questions with the word subject in it if we mean either a participant or humans, people, because that desensitizes us to actually addressing what we're trying to talk about here. I agree with Rich. And, you know, I think, again, we have in other parts of our lives so many ways we can indicate our preferences. And sometimes we're consenting, sometimes we're giving permission, sometimes we're in relationship where we're in the driver's seat. And so we're the ones that are actually asking others, will you participate with me? Will you agree to whatever it is? And we don't use the word consent in a lot of those cases. So as lovely as it is, and as much as we really appreciate what consent gave us, it's archaic and we can't rest on that bedrock anymore. It's all crumbled and we haven't noticed yet. So I would say let's look to other systems, other technologies, et cetera, that allow the variability we're going to see in humans and their preferences over different kinds of research and different kinds of communities, whether or not I'm impacting my whole family or my whole community by participating in something, or whether it is singly my decision, is one kind. And then throw in genomic information, throw in other things like financial information, and what am I comfortable with? What do I want to do? And how do I understand that I actually formulated this question that we're answering? I think that would really change the game.
Well, and Sharon, you're talking about a change of the game, and not only the logic and perspectives, but the vernacular by which we describe the nature of these changes. And isn't that one of the major obstacles that presents itself to us as we're trying to capture and honor the degree of variability that we see, both in terms of the human condition and how we gather ourselves together, as well as that change over time that you underscored, Rich. Pilar, observations in regard to this subject?
Well, I guess my first point is that a lot of this work is done without consent right now, without any kind of, consent, and perhaps the barest kind of authorization of somebody, becoming a patient of the health system and signing a 15-page document that they don't know what's in it, right? Or clicking some kind of user agreement to get an app. So right now, a lot of this is done without notice, without any comprehension that it's happening. And that's even true in health systems and biomedical research. I mean, setting aside that it's pervasive in the commercial sector, my suspicion is that even in sort of publicly funded biomedical research, perhaps the majority here is done without real explicit notice or any opportunity for people to express their preferences. And shifting to a context in which people do have a genuine opportunity to express their preferences and have those preferences respected would be in my opinion, probably a really large shift, right? That would change the nature of this enterprise enormously. And I personally favor such a shift, but I think that a lot of data scientists might feel like this puts sort of academic and publicly funded research on an even less robust footing in comparison to, say, what is done with commercially available data, right? So I just put that out there that I am hugely in favor, but it would be a really, really heavy lift to make this kind of a change. It would be a fundamental change to the way people do data science.
Tony, you've rejoined us. Thank you.
Yes, I apologize. I apologize, but for a few moments I thought it was Sharon that had frozen, and then I realized it was my computer.
Tony, we're coming up with the close of the second question, having to do with research participant consent and its complexity, and how do we remain open and embracing of that variation, and how do we operationalize our insights into it? If you have any comments to share.
So yes, I mean, I don't know how popular this would be, and it may be it's something that would need a lot of work to groundwork to be done before it can be realized. But the sort of personal health record with the owner of the record having some granular control over what is done with the data would be my favorite solution here. I mean, Sharon described one example. I don't know if Devin is still on. She described her own organization. We also had examples of big, not particularly trustworthy companies trying to do this. Microsoft, Google. That clearly was not a model that was ever going to be accepted. And indeed, their ventures failed. But beginning probably small with advocacy organizations around particular conditions and so on, if we can think in terms of growing those towards a more global system, that would be my ideal. But it's already been pointed out by Richard and others that we can't even do that for care, never mind for research. So, I'm not holding my breath.
Well, thank you, Tony. Well, I've come away with the solidified impression that the group of people who have been in this conversation are not afraid of these kinds of challenges. So perhaps it's not as far out of reach as might be the case. So let's turn to our third question. We have just under 10 minutes left to us. And that third question is, during the last 2 days, we've explored many issues associated with the pilot studies, record linkage, with privacy and security, with research participant perspectives, and ethics. Now, how do we bring these distinct conversations together? Yes, during the breakout sessions, we saw cross-cutting themes. We also saw substantial new insights and variations across those conversations in the various breakout groups. But how do we bring them together in addition to continuing to move forward along this agenda? Is there an appropriate, desirable form of governance that in some way shepherds and stewards our steps forward that have been suggested, both in the presentations as well as breakout groups and our panel discussion this afternoon? How do we coordinate such efforts? Where does the responsibility for that lie?
But, so one of the things that was discussed in our last breakout that I thought was really good was somebody said that she had been working to develop governance for data sharing and data linkage at an institution, and that she felt like she was doing it from the ground up. And she knows she's not the only person who's done this, right? And that having, models out there that are transportable, that are transparent, and sort of working on, if not yet best practices, good practices for governance at a granular level that institutions can sort of pick up without having to reinvent everything, I think would be a huge step forward. And it would take work to get there, right? And that's work that NIH could catalyze for sure.
Thank you. Richard, Sharon, Tony, further thoughts on this matter of governance?
I don't have a quick answer to this because, again, there's such a imbalance of power and information asynchronicity and all the things that I think have gutted the people being involved the way they should, that every solution I start to think about is a top-down one, which I don't think we should be promulgating. And I think about, okay, then if I go to other fields and look at community-based governance, where people organize themselves around their values and principles and create, permissions. We live in such a heterogeneous society in so many ways, particularly with regard to big data, because we can't even trace it. I mean, somebody put in the chat, do you know where your data is? It's like that thing on, do you know where your kids are at 10 o'clock? And when I was a little kid, no, I have no idea where my data is. And I'm an affluent, older white woman who doesn't have to worry about anything, employment or insurance, so it's a very privileged position for me to even think about it. Genetic Alliance ran a meeting probably 4 or 5 years ago now that we didn't run, and that was even bad vernacular. We gave meeting space and supported the communities running the meeting. And the meeting that we held was really quite eye-opening about the radical shifts that need to be made. And we had people from tribal communities and from Pacific Islander communities and Asian, Black, and Brown communities. And the sensibility is so different than what we're all sitting in this Zoom room talking about. It's astounding to me. And so I can't, in this construct, think about anything practical to say, except we have to go back to the people and give them the power to have this meeting and have us on mute and hear what they have to say.
Sharon, I'm reminded, and I won't call this colleague out, it's a member of the NIH who I'm very close to and had longing, protracted conversations with. But at one point, that person said, I know that I'm on the right track when I feel discomfort and uncertainty when I'm in the middle of these conversations, because she said, my major effort with my colleagues and I is, despite all the other acknowledgments to the contrary, is that we're trying to bring structure and direction to these conversations, and it's so difficult for us to let them go. But if we do, we have the enormous opportunity to discover paths that we might not otherwise have traversed. And I thought that was a wonderful set of insights into it. Rich, Tony, your thoughts on this matter about how do we think about governance, coordination, et cetera?
I was just going to, I'm sorry, I'm not going to add anything very positive here. I was just going to add a scary thought to what Sharon was saying, which is, imagine in the present climate that this also becomes politicized, and that it is seen as one side pushing something that the other must resist. And the disaster that could, think about unique identifier and how that has become a political issue. So I do think we need to tread carefully, and top-down probably would not work.
I could just expand upon that. That was actually a comment I was going to make as well. I think it's wonderful to see NIH looking to lead in this space, and I think that's an appropriate thing for an institution like NIH to do. That said, the kind of public engagement that would be necessary to support national policy and regulation in this space is going to require an awful lot of partners. It's not necessarily the case that this is going to be a NIH-led sort of activity, in my opinion. And I would sort of say that for two reasons, really. The first is that I think right now, given the political climate that we're all aware of, and I won't comment on, given that sort of politicization of science that has increased dramatically over the last 2 years, whoever is putting forward an initiative will be scrutinized. And NIH has its own unique set of political constraints with regard to structuring that kind of broad deliberation. The second reason is that I'm not sure NIH is a major player in this space. And that may be shocking to hear, but when I think about who is facilitating health linkage research, I don't think that that's driven by any particular IC or any particular part of NIH. I think that's often driven by large hospital systems and healthcare systems. And if you think about the commodification of health records data that we've discussed in several different ways, most academic medical centers recognize that there is tremendous opportunity to pursue this kind of research and to pivot from those very large, well-annotated clinical data sets into studies that might be quite unique and differentiating among their peers. And so there are lots and lots of folks that are in that space whose reliance on NIH funding to conduct this research would be quite limited. So I think that as NIH sort of charts a path through here, a number of less familiar players may be quite important partners. And by that, I mean hospital associations, for example, commercial entities, groups like Optum Labs, just to cite one example among dozens, Google, et cetera, may be sort of non-conventional partners in thinking about what an appropriate governance structure might look like.
And Rich, in those instances, then there's issues that are really unjust around data linkage. And so, for example, we did a project at one point where we sent computable phenotypes to a large number of academic medical centers around 10 diseases and asked for just counts. How many people do you have with these diseases? We did it for the advocacy organizations. And I'll just give the PXZ example. One came back with 136 in a California institution. And I said, would you just give them this message that we have a registry, we have a biobank, we've got research going. They said, those are our people. We intend maybe someday to do research with them, and we don't want you to have them. I mean, it was that bold, that crass, and that kind of just currency about these people, when in fact I'm interested in offering them support and connection to the only PXE research studies. There's none going on at that institution. So linkage across those institutions would be remarkable, and it doesn't happen, which is quite incredible.
Sharon, thank you for that last observation. That brings us to a close. And I think there are many bright spots despite the challenges. And I think the opportunity to continue this conversation is an extremely welcome as well as important one. So we shift gears, and it's my pleasure to reintroduce Dr. Patricia Flatley Brennan, who is the director of the National Library of Medicine. Dr. Brennan will sum up her own sense of the considerations at this point in time and perhaps give us a sense for next steps. Dr. Brennan.
I think I'm standing between you and the end of the day of a very long 2 days, very intense. I want to express my gratitude to all the participants here. I want to express my gratitude to the attendees. What we started here is a start. It's a conversation. It's not going to end in a very short period of time. I believe that the most important kudos and thanks I have to give are to the planning committee here at the NIH. You brought together the brightest, sharpest, smartest group of people, and NIH is extremely, extremely lucky to have been able to listen this way. Let me say that as Sharon Terry just said, listening is the best gift we can give to anyone. And so our responsibilities as the NIH were to listen today. And we listened and yesterday, and we listened very good and very carefully. We learned several things. We learned that record linkages is much more beneficial than we often portray it. We portray the risk. So it's critically important to address the risks to address the benefits of record linkages as we explain this to the public. We also recognize, though, that we may be a little bit farther ahead than clinical care in terms of record linkages, and providing the research community's perspective may need to be addressing record linkages as a challenge separate from the way the clinical care facilities are addressing it. And as again, Sharon indicated, the challenge is often and Brad Malin brought this up too, the challenge of the commoditizing of clinical data and the protectiveness of institutions around it may work against us. So the NIH has very important roles to play here, and these conversations were extremely helpful. With respect to the participant perspectives, I want to make sure that we remember that the person is the expert in their own cost benefit analysis. What a beautiful sentence that was, Sharon. And it brings us to the point to remember that we want to engage the person in those conversations and help them understand both the cost and the benefits. Now, when we move to the ethical issues, we tend to focus mostly on privacy, but that's not sufficient. There are many other ethical perspectives, other ethical frameworks that can be used to analyze and understand and make decisions about records linkages. We look to the community to develop those and remember the need to open up the conversation to help us understand how to apply principles in a way that it facilitates judgment. I was particularly inspired by the idea that a model of ethical stewardship that makes the research community deserving of the trust patients have placed within us represents a goal that the NIH needs to listen to and consider quite carefully. Our last couple minutes of discussion, how do we move beyond engagement? Address what we've experienced in the last year, that under a crisis, the rules of engagement change quickly, and we need to have a foundation built ahead of time, trust put in place so we can honor those trusts while we're moving rapidly in response. And the need to develop metrics and guidance for engagement is critical on many levels, on the funding level, on the institutional level, and of course, on the individual participants level. How does an individual make this choice in their lives beyond the one-off that we ask them in a moment in time? And I am proud to say NIH is understanding that reducing the burden on communities is a critical part of the research process and not simply a moment in a research project. But we need to respect communities, and we need to be able to build a history of community engagement so we don't repeatedly burden our communities in responding to us over and over again. Informed consent, we heard, is not sufficient, and we need to find ways to instead establish a partnership for engagement that allows for an endurance strategy that permits a participant to engage over the course of their lifetime, an understanding of where is their data, as Mark Weiner says, and who's got control over it, and can I change who can see this? This calls for new technologies, new approaches, and new language. And finally, we hear a challenge to knit together the wide-ranging discussions from policy to technology to ethics that we've had over the past 2 days. Governance is not set in place to do this. What is the NIH role in establishing that governance? We ourselves have to build a trustful relationship across the NIH, between the NIH and our research conducting institutions, and between the NIH and the large population of participants that engage in our research. We will be looking for your input in the future as we move forward, because we recognize community-based governance is not sufficient. We need to listen and walk together with this. I'd like to close by thanking you for your participation. We plan to establish the access to the videos of this meetings in a relatively quick process. There will be a written report presented to the NIH for the deliberations. And I would like to go back to Valentina and Dina and your team and say, terrific work. Thank you so much. Susan, I'm going to let you do the closing.
Well, I only want to echo very quickly what Patty has said and others, that I really want to thank each and every one of you for participating today in your discussions in the panel, your questions and answers. This has been one of the best meetings that I've attended in a really long time. The content and the thought and the scientific discourse has been unbelievably valuable, and nothing will be left on the table. Although we may be slow in our actions, we will have actions. And so with that, I just want to thank you again and wish you a very wonderful holiday. And hopefully you will see us in other venues, including our webinar on July 9th.
July 9th.
July 9th, thanks.
Thanks, everyone. Happy holiday weekend.